All right. Thank you so much, Carrie, for the wonderful introduction. I want to start off by thanking everyone for their time today. Again, I am Dr. Sajan Shah, one of the pain fellows here at Stanford, and welcome to this talk on gate control theory and pain management. Pain is a universal human experience, but did you know that your body has built-in mechanisms to control how much pain you feel? Well, today we'll explore how the nervous system processes pain and how we can use this knowledge to manage pain effectively. So I've titled the presentation today as Unlocking Pain, Exploring the Gate Control Theory of Pain. And I think that encompasses a lot of what today's talk will be about, because it's really figuring out how do the pain signals travel in the body? Where do they go up from? And how do they get controlled from up to down trajectory? Now, all of that sounds kind of vague to you right now, but I think it'll make more sense as I continue along here. I want to take a moment to explore a reaction we have to pain that will help to bring this whole presentation to become more relatable. So I'm going to give you a moment to think about this. What do you do when you feel pain? What do you do when your shoulder is sore, for example, like this gentleman on the left whose left shoulder is hurting? How about when you step on a Lego, stub your toe, or injure your foot while exercising? Similar to this gentleman on the right who's sitting on the ground sort of with a foot that seems to be hurting. Take a moment to think about your initial reaction, as this will be important for you to really understand this presentation. All right, I think that's enough time. And you can continue thinking about this as I speak about the other slides. And again, I want you to think about, what do you do when you feel that initial moment of pain, or when you feel that recurrent pain come back in a more exaggerated form? What is it that you do naturally, rather than just take medications and all? But what is it that you want to just viscerally do when it initially starts hurting? Now let's zoom out a bit and let's talk about general statistics surrounding pain. These statistics come from 2021 that was published by the Center for Disease Control, the CDC. 1 in 5 adults in the US suffer from chronic pain. This is by definition pain lasting greater than 3 months. That's 51 million US adults. That's hard to believe. 6.9% of the US population experiences high impact chronic pain. Now, this is pain that substantially restricts daily activity. That again is a remarkable statistic. These are people who are not able to work and provide for their families. These are patients who have pain that results in frequent visits to the emergency department, frequent hospitalizations, and frequent visits with their doctors. This takes them away from their daily activities, their daily things that they love to do, and their families and friends. This is a remarkable amount of people that face pain on a day-to-day basis, especially with high impact chronic pain. And I think it's worth talking about the ways that pain develop and the ways that our bodies have mechanisms to combat pain. So what is pain? We use the word pain to describe many different types of sensations that cause us discomfort. Per the IASP, or the International Association for the Study of Pain, pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. Now, this is a very technical definition, but the reason I wanted to share it with you is so that you know what is sort of the textbook definition that we think of when we think of pain. And again, it's rather vague. It's any unpleasant sensory or emotional experience, I should say, that is associated, again, with actual or potential tissue damage. And I want you to pay attention to that. I'm saying, again, potential tissue damage. It's not always that there is tissue damage, but that there might be. And again, pain is a very broad category word. And so this can be further broken down into acute and chronic pain, as I've alluded to previously. Before we begin defining these two subcategories, I wanted to first develop a framework utilizing anatomy. But even before that, I have a fun little slide here. And I wanted to take a moment to acknowledge that pain cannot be defined by any one sentence or paragraph. I think it's very easy for physicians to use these sentences and tell patients, look, this is what pain means. But it's not that easy. And especially pain, a very vague topic, is difficult to put into just one sentence or even one paragraph. It is a deeply personal topic. It is hard to describe. Pain isn't just physical, it's emotional, existential. And for centuries, art has been one of the most powerful ways people have made sense of their pain. Whether it's Frida Kahlo painting her spinal injuries, as we see on the left here. Now, I did cut off a portion of this image just for the public-facing nature of this presentation. But I encourage you, if you'd like to see the rest of the painting and see if you can relate to it. And in it, you can see that she's actually painted in sort of needles stabbing her throughout her body. And she points out her spinal column as a column that has been disrupted, and that's causing her pain. On the right, we have Edvard Munch's Scream. Now, I'm sure a lot of you are familiar with this one. And it really helps to reflect anxiety and stress. And I think paintings often can describe what we cannot describe in words because they just do a better job of explaining what's happening. So I encourage you, if you are someone who likes to draw or explain things in images or in art, then use that to explain to your providers or to even to explain to yourself what you're feeling so that you can put in better words what it is that you're experiencing. Because the more we are able to share what we experience, the more we can connect with each other and come up with a solution. These art forms are another window into what patients are going through and why pain is more than number on a scale. The reason I wanted to take this detour is to acknowledge that the technical explanations of pain pathways and pain processing I will provide in the rest of the presentation do not fully encompass the lived experience. But I do have to start somewhere to explain all of this. And I just wanted you to know that I do acknowledge that the rest of the presentation is technical, and that may not cover everything that you or your loved one may be feeling, but that we have to start somewhere in talking about these topics. Now with that, let's go back to that anatomical pathways that I wanted to discuss to describe pain. So here is a normal pathway. In this diagram, we see pain starting at the hand. We call this a nociceptive input or a pain input. This leads to the communication of this pain signal. So here we see a nail stabbing into the hand and it turns red, indicating that it's pain. And there are nociceptor endings, meaning pain endings, that transmit signals to the dorsal root ganglion, which is this structure right here. It's a structure just outside of the spinal cord. And then this signal then travels to the spinal cord and then up to the brain, where the higher functioning and processing centers are. Now, this is another image that shows the same thing, but in a different way. Again, here we see a hammer hitting the thumb. The thumb sends packets of information that get communicated along the way up to the brain. So I want you to follow that along. The hammer hit the thumb here, and we see these packets, which are these little dots, climbing up to the dorsal root ganglion, which is this structure, to the spinal cord, and up the spinal cord to the brain, where those central processing centers are. Now, I'm going to use this model and the previous model to map out all the different things I'm going to talk about today, the different treatment modalities we have, the different medications we use, where they act, how they act. I won't be focusing as much on medications, but it will be a part of this topic in some shape or form, but mostly the different interventional treatment modalities we have. And this will provide a very good framework for us to discuss those. So just take one more moment. I'm going to just say it one more time. You see the pain starting here at the thumb with the hammer hitting the thumb. The pain signals are then traveling down the arm, down to closer to the spinal cord where the dorsal root ganglion is, and then the spinal cord, and then up to the brain. Now let's go back to that definition of pain and those subcategories I wanted to talk about. The first subcategory is acute pain. Now this is pain that is defined as pain that is less than 3 months. Acute pain is a protective response by our body. It alerts us that something we are doing or that is being done to us is causing tissue damage. It allows us to change our behavior, avoid certain mistakes. For example, this gentleman here who either is about to touch or has already touched based on his facial expressions, this hot iron. You can see how such a response is important to our survival. Once we feel that once, we don't do that again because that pain signal is important to tell us that if our hand continues to stay there, it will get damaged permanently by either very severe burns or more. So next time you ask, why do humans even feel pain? Why are we created this way? Just remember that pain can be our friend and that it's a survival response, and it's actually very important for us to be able to feel pain. So that brings us to chronic pain, the less useful one. Chronic pain is not as helpful in helping us survive, but it is a process that occurs in our body. It is essentially when the normal pain conduction pathways become abnormal. The original pain signal in the hand, for example, does travel the same route, but somewhere in between the processing is altered and it incorrectly gets transmitted to the brain. In the absence, and sometimes then you'll have pain in the absence of a sinister cause. This needle or nail may no longer exist, but you still have these signals going up, and we don't have an explanation for that all the time. Now, you may have heard some people mentioning that they have a higher pain tolerance, or maybe a lower pain tolerance. Why is this the case? Why do some people experience pain more intensely than others? It almost seems unfair. Why do some people have to face more pain? I mean, you give two people perhaps the same exact amount of pain by either pressing a needle into their hand or pinching them, but one person may feel more pain from that than the other, even if everything else was the same. Well, I won't be able to explain all of that, but I do think the gate control theory provides us at least a portion of the example of the explanation of why this occurs. So let's talk about how pain is regulated. As pain travels up from the site of the pain, which again is in the hand here in this image, back up to the brain, the spinal cord actually plays a role in processing this pain. After the pain is put through this processing center, it is then that the brain receives this processed input or pain signal and decides how it is perceived. So you can see how this spinal cord is kind of acting like a barricade between the brain and the area of the pain that is being brought on. I think this is a good time to start talking about gate theory. So here's that slide that you saw at the beginning of the presentation. Again, with the guy on the left with left shoulder pain and the guy on the right with the foot pain. Think about again the question I asked you. What did you do instinctively the last time you stubbed your toe or strained your neck or shoulder? Well, personally, if one of these things were happening to me, I generally end up rubbing that area or applying pressure to that area. That's what makes me feel better when this occurs. And this isn't just a random reaction, actually. It's your nervous system using built-in mechanisms to alter pain perception. Basically, what I'm telling you is that you've actually been taking control and advantage of the gate control theory this entire time. And today we'll explore why that works. So let's go back a little bit and talk about the basics of the gate control theory. In 1965, researchers Ronald Melzack and Patrick Wall proposed the gate control theory of pain. The idea is that the spinal cord acts like a gate that can either allow or block pain signals from reaching the brain. Imagine a road with a toll gate, as we see here. If the gate is open, cars, which would otherwise in our body be pain signals, pass through freely because the gate is open. If the gate is closed, however, fewer cars get through, and it would have to be opened up by some sort of allowance to be able for the car to pass through. This reduces the cars being on the highway and the overall traffic congestion. Similarly, it would reduce the amount of pain signals that are being transmitted up to the brain. Non-painful stimuli, such as rubbing your elbow after bumping it, or like I showed in the past slide, rubbing your shoulder when it hurts, can actually help to close the gate and lessen the pain. Imagine that you put a fee at the toll road and you increase the fee, and the gate is now harder to open because the passenger in the vehicle, the driver, has to pay a higher fee to get through. Now, that might be a little bit of a stretch in terms of the analogy, but I'm going to roll with it anyways. So how does the theory work? Let's get technical. Here is a more technical diagram of what I've been explaining. Pain signals travel through two main types of fibers, small and large. Small fibers called C fibers, and there's another one, but those are less important. So let's just stick to talking about the C fibers. These tiny fibers actually carry pain signals, and they open the gate. Large fibers called A beta fibers carry touch and vibration signals that help close the gate. This is why massaging or applying pressure to an injury can reduce pain. But the gate isn't controlled by physical input alone. Psychological factors like stress, anxiety, and attention also play a role, and we'll talk about this further. If you focus on pain, the gate opens wider, making it worse. If you distract yourself, for example, the gate may close slightly, reducing the pain you feel. Now, I just want to take a moment here to point out that I am presenting an oversimplified model of the gate control theory. But I think this simplified model is enough for us to understand and talk about the gate control theory, just to give us a framework, because that's what's important here. I don't think understanding all the tiny molecules and all the different reactions that happen in our body that actually cause the gate control theory to work is that important for us to understand during today's presentation, and is actually outside of the scope of this presentation. Now, I gave you a lot of information, but I want to bring you to this image. We see the small fibers here and the large fibers here. Small fibers are the painful signals generation, and the large fibers are the non-painful generation. There's no input in this first image, which is why we don't see any signals being passed. Let's move on to the next one. Here we see that there are large signal inputs being made. And what that does is it closes the gate, which we're calling this, which are little interneurons, neurons that activate nearby neurons, that then don't allow these small fiber signals to pass through. So here, as we see, the large fiber is sending signals that are non-painful up to the brain and closing off this gate, and we don't see any pain signals being transmitted after that to the brain. Now, in this last picture, we see that there are no large nerve fiber signals being passed through, but we see that the small fiber is passing, and it's actually opening the gate up, which allows this gate to stay open and for pain signals to pass through, as we see here. We'll keep talking about this. Don't worry if you didn't get it on the first go. So, as promised, here's another example of it. And I really want to drive this point home because it's going to give us a basis to talk about the rest of our lecture. So here at the top, we see a hammer, an arm. And the reason I chose this again is because it's very similar to that first model I showed you and keeps things simple. Hammer to the hand. And that would be a painful signal here. Here we see a hand rubbing. That would be a non-painful signal, which here is labeled as a mechanoreceptor fiber. So here in this first image, we see that there has been no injury yet. And this is just the baseline. There's no signals passing through. We see this interneuron, which is a connection between the painful and the non-painful signals, and that this goes up to the spinal cord. And then these signals then eventually travel up to the brain. In the second image, imagine the hammer had already hit the hand. Now, I wish I could have played you the video, but I didn't want to make it so that the video doesn't work and then I fumble around. That's why I wanted to keep it simplistic. But imagine this hammer had already hit the hand and the hand is now hurting. And that you can see that through these tiny little red dots, which present pain signals being passed along to the spinal cord. Because there's no non-painful signals and only painful signals, you can see this gate is open and allowing signals to pass through to the spinal cord. And oh, there's another red dot up to the brain. The thalamus is the first part of the brain that it usually goes to. Now, in this last picture, we see a hand rubbing the other arm. You can see that this causes non-painful signals to transmit through. And you can see that by these little dots here that then go here and actually close off the gate. And that's where this bar comes in. The gate is now closed. So this patient is able to feel the rubbing as a signal in their body. But now these red dots are going to stop right here. And it won't be able to reach the spinal cord, which thus means it won't be able to reach the brain. So you can see now how these two things interact with one another. So now I want to talk about what causes the gate to open and close. Take a moment here. I'm going to give you 10 seconds just to read through these because there's a lot of words on this slide, but I think they're all very important. All right. I'm sorry if that wasn't enough time for you, but I will be talking about all of them, so you won't have to worry about not catching all of it yet. So I put the gates here rather than open and close, just so that you can get an idea visually in your head. Open gate means painful signals passing through. And so that's why I made all of these in a red background, whereas this is a closed gate, and this is a not red background because these are not painful things. So I'm going to talk about what causes the gate to open first. Physically, this could be any sort of degeneration. This could be things like arthritis, as you may or may not have heard you or your loved ones having. It could be medical pathology, diabetes, other medical conditions, cancer, for example. It could also be immobility, not moving too much. This can cause your body to deteriorate and can cause this gate to open. Emotionally, this could be stress, anxiety, depression, anger. Do you remember the last time you stepped on a Lego? Were you happy then, or were you sad then? Imagine you just came home from a really hard day at work or a really hard day in general, and your mood's just not that great. And then you come home and you step on that Lego. It's going to hurt a lot more. This may explain it. The gate's now open. That allows those pain signals to go freely through the gate. Similarly, behavioral activities like inactivity or even overactivity, overdoing it one day, for example, going for a longer run than you're used to, going for a longer walk than you're used to. These things can cause the gate to open, which might explain why you have a little bit more pain during that time. There are also social determinants that cause the gate to open. This would be people who have poor support at home, where they just don't have the family support or the friend support. When you feel isolated, these things can cause your pain to feel amplified. And that again goes back to the gate being open. Thoughts such as fixating on a certain pain or catastrophizing can all cause these gates to open. Now, what can cause the gate to close? Similarly, I have labeled them in similar categories so that you can kind of see how they relate to each other. Physically, medical interventions, medications, exercise. These are things we'll talk about, but they all help to close the gate. Emotionally, relaxation techniques. Imagine if you came home now relaxed and you had a nice day, and then you step on the Lego. Maybe you're having so much fun with whoever it is that is playing Lego, you're playing Legos with, that it doesn't even bother you because you're distracted. You're enjoying yourself. The pain signals are not able to pass through. The gate's closed. Behaviorally, this could be pacing. Taking your time to increase how much activity you can do, not overdoing it so that you're not straining your body. You're giving it time to rest and relax before you push yourself a little bit further the next time. Physical therapists and occupational therapists often talk about this technique because it's very important to help with pain. Socially, this could be positive support or community involvement. And then finally, through thoughts, distraction, like I mentioned earlier, or rationalization, thinking through it. These all can cause the gate to close. I want to take a moment now to talk about the 4 P's of pain before we continue talking about the gate control therapy or theory, because it is really important to understand our approach to managing pain here in the Stanford Clinic. This stool is a great image to keep in mind. Each leg of the chair represents a fundamental foundation to managing pain. And without one of the leg, imagine the stool would fall over, and similarly, your care would be destabilized. So the 4 legs are psychology, physical therapy, pharmaceuticals, and procedures. And we take this approach because pain is complex and multifaceted and requires a complex and multifaceted approach to manage it. Again, without one of these legs, the stool is no longer stable. Imagine you're sitting on the stool. Once one of those legs is gone, that can destabilize everything and cause the pain not to get better. Now, if you recall the previous slide and what opens and closes the gate, you'll see that each of these legs address those factors which open and close the gate. They're broader categories. And that's why we take that type of approach here at the Stanford Pain Clinic. We can use the previously discussed model now to discuss how we leverage the gate control theory. Here, we lay out each of the 4 legs of the stool and how they fit into the gate control theory model. Let's use this slide as a framework for the remainder of the lecture. Here, we have three categories: the peripheral nerve, spinal cord, and brain. Again, it's because the signal travels from the peripheral nerve to the spinal cord and then to the brain. So by nature, we try to target pain signals at all 3 different targets and see if we get a response in a patient. At the peripheral nerve ending, we can do physical therapy, occupational therapy, and desensitization training as part of this regimen. There's also transcutaneous electric nerve stimulation, radio frequency ablation, peripheral nerve stimulation. At the level of the spinal cord, we have spinal cord stimulation, dorsal root ganglion stimulation, again, that little structure right before the spinal cord. And then at the brain level, we have pain psychology techniques that affect thoughts and emotions. And again, recalling what opens and closes the gate, you'll remember that thoughts and emotions are very important. There's also cortical stimulation and deep brain stimulation. These are neurosurgical techniques, and they can be used in patients who have refractory or difficult to treat pain to our normal modalities. Now, I know I said a lot, but this was just to create a framework. Let's proceed on. So now I want to talk about neuromodulation. This is a relatively newer technique, and it really leverages and takes advantage of the gate control theory. It was founded in that principle, and this technique has been very helpful to many patients. What it does is it develops the non-painful signals in the body to close the gate, or to train the pain pathways to process pain pathways differently. As we saw in the previous slide, neuromodulation can be done at any level of the model of gate control theory, from peripheral nerves to spinal cord and even to the brain. The benefit of this technique is the reduction of pain perception without medication, or at least that is the goal. And the best part, it is often reversible. Now, there are many things that can affect the gate control theory. But given that I want to talk about this from a perspective of pain control clinic or pain management clinic, I think it's very important to bring neuromodulation into this conversation. And it will help to also understand gate control theory. Now, we must keep in mind essential points about neuromodulation. Big word, we'll keep explaining it, but I want to just bring up these important points. Patient selection is key. Using the wrong tool for the wrong purpose is a recipe to disaster. For example, you wouldn't use a screwdriver as a hammer or a hammer as a screwdriver. It's just the wrong tool for the wrong purpose. It is also important to assess pain condition globally and determine whether using the gate control theory is favorable. For example, is a patient likely to benefit from a procedure or intervention? Does optimization of the patient need to occur before? For example, if they have diabetes, if they have high blood pressure, other issues, do we need to control those first before we go and do these procedures to affect the gait control theory? We also need to measure whether these techniques offer functional, psychological, and/or symptomatic improvement. This is just an overview of some of the options we'll discuss here in a bit, just so you can see how varied our approaches are of neuromodulation. You can see it goes from non-invasive to very invasive as we go from left to right and top to bottom. Let's talk about the first technique, transcutaneous electrical nerve stimulation, also known as TENS unit. You probably have heard about this one, but if you haven't, no problem. Let's chat about it. This is a non-invasive neuromodulation technique that uses low-intensity electric currents through electrodes placed on the skin, as you see in this gentleman here. The electrical impulses stimulate the nerves and can help relieve pain. You can see here a picture of this gentleman treating his upper back pain with the TENS unit. These come in many different shapes and forms. When you Google this or look up any resource for different TENS units, and if you want to purchase one, these are over the counter, which is the best part about them. You do not need a prescription for them. You will have a lot of options to choose from though, but just remember, they're all pretty much the same. They all do essentially the same thing. The thing that changes between them is some of them are fancier and have different controls and different settings for different parts of the body, but some of them are simpler. You just increase the stimulation or decrease the stimulation, increase the frequency, decrease the frequency. They all come with the same types of electrode patches and all come with that little modular device to control those patches from. So where does TENS fit into our model for gait control theory? Well, here you could see the TENS unit and the electrodes placed on the skin. It causes those A beta or non-painful signals to go through, which then puts a blockade of the incoming pain signals from the C fibers, which you can see here. I think you're starting to get it, right? Now let's talk about peripheral nerve stimulators. These enact change at the level of peripheral nerves. This technique is most helpful when there is a distinct peripheral nerve distribution. There are many different options within this category. We have radiofrequency ablation, which is a one-time spot treatment of a peripheral nerve with electrical impulses. We also have temporary nerve stimulators, which are microwires placed near the nerves to treat for a predetermined duration with an external pulse generator. Big words. Essentially, we stick a tiny wire inside next to the nerve, attach it to a little battery pack that stays outside, and that allows you to control that lead and stimulate the nerve from the inside. So you can imagine the TENS unit sort of acts from the skin level, but these techniques really go down to the nerve level. But because we're targeting specific nerves, it can only impact an area that that nerve gives sensation to. So it won't be your entire leg, for example. But for example, if we target a nerve that's on the side of your lower leg, then that whole lower leg side of your, the whole side of your lower leg will then feel that relief if it is that nerve that is hurting. So here we see someone who has knee pain and they're getting genicular nerve radiofrequency ablation. And these needles are placed down to those nerves that then cover that sensation coming from the knee. Once this procedure is done, the gait control theory helps to block the signals, pain signals from traveling up to the brain. And it can help a lot with knee pain. This patient has a temporary peripheral nerve stimulator for the shoulder. And so when we turn on this device, it sends non-painful signals which block the pain signals from reaching the brain for the shoulder. And similarly, we also have permanent nerve stimulators. Let's say you got the temporary one and it was very useful, but these things can only stay in for 60 days because as you can see, it stays outside your body. While the permanent ones are actually implanted into your body and it's actually closed off at the skin. And then you can just apply this sticker on top, which has a transmitter, and it's connected to a device where you can control the settings from. And if you were to have any of these techniques, you would have a device representative who would walk you through how to use these things. Now let's chat about spinal cord stimulator. This device enacts change at the level of the spinal cord. So we've talked about skin, peripheral nerves, which kind of fall in the same category. And now we're getting to the spinal cord itself. It provides a more central target for the electrical impulses that are not painful, which then go to the spinal cord and block the pain signals. And thus, this allows a greater area to be covered because now we're really going central and it's not so much to the periphery as I was explaining with that lower leg example. It is placed outside of the protective layers of the spinal cord in the epidural space. So it's also called a dorsal column stimulator. We generally start with a trial that lasts generally 3 to 14 days to ensure that the technique helps with pain. Then, if we have a positive response, we progress to implantation. There's a whole field that exists in developing the types of electrical impulses that are sent. There are modes with paresthesia, modes where you don't feel anything, modes that respond to changes in electrical impulses in your body, and more. And more research just keeps coming out in this space on how we can optimize these electrical signals to take advantage of the gait control. These also come with rechargeable or non-rechargeable batteries based on the patient. This is a schematic that shows you an example of the procedure. As you can see, it's rather minimally invasive. Now, just a heads up, this is a neurosurgery way of doing it. Our technique at the pain clinic is less invasive. However, there are patients where the less invasive option is not an option, and they have to be referred to a neurosurgeon to do the slightly more invasive procedure where a little bit of bone has to be taken out. But for our purposes in the pain clinic, it essentially involves 2 incisions, one for the battery and the other for the cables to be inserted. And these cables are then inserted up the back to the level where the spinal cord branches off and can help to control pain in the legs, for example, or the back. So how does the SCS fit in the gait control theory? Now, I know I've already kind of explained it, but we see here that the SCS device provides non-painful A beta fiber signals to the spinal cord, as we see here, and it closes off the gate. As the gate is closed, these painful signals are no longer able to reach the brain. It's the same topic, same conversation, same thing I'm repeating over and over again, but it's important because it's a hard concept. If we simplify it and repeat it, it'll start to stick in our brains. And so, again, SCS works on that same gait control theory, non-painful signals blocking painful signals from reaching the brain. There's also dorsal root ganglion stimulator, very similar to spinal cord stimulator, except as you may remember, it's that area right outside the spinal cord that we're targeting. Similarly, we can place microwires there, do a trial, see if it's effective, and if it works, we move on to the implant and place it for pain control. So why would you do this instead of spinal cord stimulator, which covers a broader aspect? In general, why would you do spinal cord stimulator? Why would you do anything other than spinal cord stimulator, which seems to impact a broader range? Well, you don't always want to cover everything. You just want to cover what hurts. And a bit more targeted and precise control actually leads to better pain control. So if you just have pain in your foot or your groin, then you might want the dorsal root ganglion stimulator. However, if your pain's in both of your legs, then the spinal cord stimulator is a better option. And if it's just in a tiny area supplied by one nerve, then that's where the peripheral nerve stimulator comes into play. There are many other targets. I can sit here and tell you all the different types of techniques that we offer. But I think now, if you ever want to think about this topic and want to think about an option that is either being presented to you or to a loved one, it'll be a little bit more understandable. And you don't need to go through all of the different techniques because now you have an understanding of the basic fundamental principle that these techniques are based on, which is that gait control theory. Now remember, that's not the only thing. And we will probably find in the future that there are other mechanisms by which these devices and procedures are helping. But for the sake and scope of this lecture, the gait control theory is a focus. And that's why we'll be talking specifically from that lens. Other targets I just wanted to briefly mention here are things like multifidus muscle stimulator, where we actually place leads outside of the spinal cord area, outside of the nerve root area, and just place them along the nerves that feed the muscles. And it actually helps with people who have low back pain with muscle weakening. Higher up, there's techniques that neurosurgeons do called deep brain stimulation that actually enacts change at the level of the brain. This is performed by neurosurgeons. And these techniques help to treat resistant functional movement disorders. Microwires in these cases are placed in the brain at specific points that neurosurgeons have developed. Again, all these techniques all come back to that point of the gait control theory. So, is neuromodulation the solution to all pain? Well, although it appears that this should be able to stop all pain pathways from reaching the brain, in reality, it does not always do this. And when it does, it is not guaranteed to block 100% of pain signals. Because while I made this simplified and showed an open and closed gait, the reality is that the gait can be in many different degrees of open and closed. And as we discussed, pain is multifaceted and complicated entity. And thus, it must be addressed with a multi-pronged approach. This is where that stool returns. We must utilize physical therapy, psychology, and medications in conjunction to restore function and improve psychological and painful symptoms. Like any medical intervention, neuromodulation has both benefits and risks. On the positive side, it provides significant pain relief for many patients with chronic pain, often reducing the need for opioids or other medications. There are both non-invasive options like TENS units and implantable options like spinal cord stimulators. However, risks include potential infection, lead migration, and complications with the device over time. A thorough evaluation is necessary before determining if neuromodulation is the right choice for a patient. We need to make sure that a neuromodulation procedure is a good fit from a psychological perspective. And we thank our pain psychology colleagues for their expertise to make this determination. It is also important to ensure a patient has a good support system in place and that medical comorbidities are well managed and not barriers to successful use of these techniques. Uncontrolled diabetes, for example, could result in a significantly heightened risk of infection with spinal cord stimulation implant. So what are the benefits of neuromodulation? Well, it provides long-term relief. Other treatment options may be short-term or have intolerable side effects, like opioid medications. It may lead to functional improvement over time. It could also improve daily participation in activities, sleep, and overall well-being. And neuromodulation continues to grow. There are newer and newer techniques that develop, and we are excited to continue developing on those. The other nice part is more and more providers outside of pain medicine and neurosurgery are becoming familiar with these devices so that if you do go to another physician or show up to an ER, they're familiar now with these devices more and more so, and so that it won't complicate your care in the future. Additional benefits, again, it's able to be reversed without causing nerve damage or long-term problems. But sometimes it can have an issue with taking it out. But that's usually not the case. The settings are also adjustable and customizable to a patient's needs, individual needs, not just population needs. And it reduces your reliance on medications and provides a more targeted therapy, avoiding the side effects that often are due to techniques that affect the entire body. So what are the key takeaways? I know I said a lot, but hopefully with the repetition that I provided, I was able to give you a better sense of what gait control theory is and how neuromodulation fits into that picture and what options we have. Pain is both a physical and psychological experience. And I think this is a very important takeaway because often we're always looking for a physical reason to treat our pain, but it's important now that you have an understanding of the gait control theory to see how all these other legs of the stool are also important, especially that psychological experience. Gait control theory explains how pain signals are filtered. Neuromodulation can reduce pain by closing the gate. And effective pain management requires a wholesome approach of not only procedures and medication, but also physical therapy and psychological therapy. And finally, treatment should be tailored to each individual. And I am a huge proponent of that. Anytime I see a patient, I always see them in a new lens and don't compare them to any other patient I've seen because each patient's lived experience is different. And again, that goes back to that artwork I shared with you. This is just one more thing I wanted to share with you before we wrap up here. These are some next generation tools to hack the gate. Now that you have an understanding of the gate control theory, it'll be more fun when you go online and see some of these things pop up on news articles. We spoke primarily about neuromodulation during this lecture, but we're seeing an exciting wave of high-tech solutions to chronic pain. Virtual reality can actually distract the brain enough to reduce pain intensity. This is already being used, for example, for burn victims during dressing changes. Biofeedback apps help patients learn how to calm their nervous system. Even video games and gamified rehab tools can make physical therapy fun, which helps retrain the brain's pain signals and close the gate. Now, all of these things are unfortunately outside the scope of the talk, but I wanted you to know that now you have the ability to see these technologies that are appearing in a new lens, in a new light, because of your newfound knowledge and understanding of the gate control theory. Thank you so much for listening today. It's been an absolute pleasure to be able to share this information with you. Here are additional class and group resources, as Dr. Meltzer had mentioned at the beginning of this lecture. And now I'm open to taking questions and providing answers to questions that I can provide information for.